Thanks, David, and thanks to Crohn's Colitis UK for asking me to speak today. Quite a daunting prospect, actually, to come and talk about self-management to so many patients, because from my own experience of being an IBD nurse over the last 7 years running a self-management programme, we do get real mixed reviews on whether this is the way forward that we should be taking. So what I want to do today is to talk to you about, like we've heard from a previous speaker, that conventional follow-up doesn't work. Okay, patients require quick access to expert advice and support for patients with inflammatory bowel disease. Well, let's turn it round a bit. What if the best person to give that advice is the person who's got inflammatory bowel disease? We hear from you regularly that your GPs don't provide you with enough support, or you can't get access to your healthcare team. So maybe thinking about self-management is a way that we can address some of those issues that you see. So I almost feel like I have to give you the case for inflammatory bowel disease and why self-management is an important approach to managing it. I don't have to tell you this. IBD is a chronic condition and it's unpredictable. How many of you have come for a clinic appointment and then 2-3 weeks later had a relapse of their inflammatory bowel disease and tried to get back into clinic to get an appointment? This happens regularly. As an IBD nurse, we get quite frustrated because we fill our clinics and try and get you all in and sorted, and then patients don't turn up for their appointments. And maybe out of a clinic of 7 or 8 patients, probably 4 or 5 patients will turn up. The remainder will not turn up. So that gives us 3 empty clinic appointments in most clinics that we see, which, if you had IBD that wasn't settled, you'd really value to be able to use that appointment space. And again, I don't have to tell you this, but patients with inflammatory bowel disease face immense challenges. You've got to juggle your illness with living normal life. And I think one of the stories that kind of I always take with me on my journey of working as an IBD nurse was listening to a chap who had colitis. And it wasn't the diarrhea and it wasn't the rectal bleeding. It was the fact that he couldn't get out with his family at the weekend was the thing that made the difference to him. He could cope if he knew, if he could manage his symptoms, but quite often, because his appointments were prolonged, his symptoms worsened before he was able to get help and reduce his symptoms. And I think the other is most people are working, they're of a working age, and therefore 9 to 5 hospital services don't reflect what we need to support you with inflammatory bowel disease. So the Americans developed this Kaiser-Permanente pyramid years ago, and what they suggest is that if you've got a long-term condition, 20% of those people will have complex long-term conditions that does require regular contact with secondary care. 20% of people can have supported self-management, but over 60% of patients are able to self-care. Yet we don't tackle or address those issues. We don't spend time talking about what you need to do when you're well and to plan for when you're unwell in clinic. So really, what do we mean by self-management? So it's about being able to equip you with the skills that you need to develop and participate in decision making, giving you the confidence that you need to ask and challenge your healthcare professionals whether the care you're receiving is right, and if you're not happy with it, what do we need to do? But to do that, we've got to share with you the knowledge, the information, point you in the direction of the good quality resources that will help you to build your knowledge base. We also want to, it's also about getting you to reflect on what your symptoms are. So a lot of patients, before they get the diarrhea, before they get the rectal bleeding, will complain of tiredness, weight loss, loss of appetite. Well, surely it's easier to recognise that as a red flag symptom rather than waiting until a full-blown flare has occurred. So when we talk about self-management and where I work, it's not just one clinic appointment will equip you to manage yourself independently. It probably takes a number of consultations to get patients through this process. So I have to understand what the experience is like for you, so then I can help or support you to adjust a cope with the physical and psychological demands of your diagnosis, and to share with you then potential skills or get other MDT members in to enable us to support you. And sometimes it's about sharing your experience with members outside, just and share your experiences. A lot of patients that I look after don't tell family and friends how they're feeling. Don't tell family and friends that they have inflammatory bowel disease and the implications of that diagnosis. I have patients who don't share with their employers because they're concerned of how that will look and the implications for employment. And I think talking to us, I can remember as a specialist nurse when I very first started in post, I was really scared to go and speak to a consultant to ask them about what I should do with somebody. Well, if I'm intimidated, lacking confidence to address that situation, I'm sure many other people feel the same. So to summarise, really, self-management is about developing decision-making skills and getting you to learn to evaluate the new treatments and what we're asking you to do. We want you to challenge us. We want you to ask whether it's right, because if you buy into a treatment option, it's more likely to work for you than if you're slightly hesitant against it. And there is science behind it, and what we know is that patients with inflammatory bowel disease have poor knowledge. There is a perception that the knowledge base is good, but when we question and drill down that further, actually the knowledge of what IBD and the treatments available is generally very poor. To give you some assurances, and I think Veronica will probably touch on this on a later presentation, is that also a lot of healthcare professionals' knowledge is actually poorer than the patient's knowledge also. But we know that if we improve your knowledge, that it enables you to cope and adapt to your challenges of your diagnosis. So David's touched on social media already, and it causes us a headache. I follow the Facebook page, but just to give me the heads up of what questions are going to come into clinic over the next 10 to 14 days. Because I think it is a really valuable resource for people to anonymously ask questions, but also it's a great way of sharing experiences. There's loads of information on the internet. If there's no Americans, then I can say the mad Americans tend to frighten the masses because they write up quite shocking stories and suggestions on how inflammatory bowel disease should be managed. But the internet, and what we know from the work that we've done at Salford on the portal, is that people on average use the computer between 4 and 6 hours a day. That's whether they're at home or work, so it's an integral part of society. 80% of us have a smartphone. So again, you know, that contact for information. And I've touched on the portal already. We use the self-management programme at Salford, and we've used it for about since 2007. We initially used a paper-based service, but we've recently been fortunate to receive funding from Crohn's Colitis UK to develop an IBD portal, of which self-management is going to become fundamentally underpinning this. What if? So this is it. Have you planned for your flare? Do you know that if your symptoms happen, what strategies you should go to? Not many people do, and it's not a conversation that we commonly have. So what you need to do is to challenge your healthcare professionals about having a plan of interventions. IBD changes lives, but it doesn't end it. So it's really important that you can accommodate and have planned management plans in place that support your IBD. And I've alluded to already, I think the importance for the foundations of good self-management is engaging with your family and friends and your healthcare team. So who's it suitable for? I don't think it's suitable for everybody. I think it more suits patients who are in remission or have mild disease. And I think more patients who are receiving DMARDs or biologic treatments, it's slightly dicey to go down that line. So these are the things that we would talk about in the self-management programme. Reflect on your disease. And it still astounds me, you know, when I come across somebody who's been diagnosed for 15 or 20 years who doesn't know about what the disease is, what part of the bowel is affected, and really to get the understanding of recent endoscopy, radiology reports, those kind of things. I get you to think about what your symptoms are when you're well. So when I'm well, I go to the toilet how many times? That's your baseline. And then we'd move on then and say, well, when you're unwell, what are the red flags that you see? And I don't have to say that many of you experience these already. And then last time when you had a flare, what were the interventions that you put in place? My appetite was less, I noticed I lost weight, the urgency returns, my bowel frequency increased, and getting you to isolate and identify those flags. The biggest part of self-management is getting people to understand the medications. What we know is that 40% of flares in ulcerative colitis is a result of poor compliance with medicines. And by that, we don't necessarily mean just not taking your medicines for a week. It may be that you missed one dose, missed 2 doses, but if you miss 1 dose every week over a period of time, it will have an impact on the control of your inflammatory bowel disease. The other is that over a period of time, people naturally forget what the doses are. And what you'll see is that people will knock off 1 or 2 tablets and drop the dose down. And then they'll forget actually what the normal tablet dosage was to take. And then other people stop medications due to being unwell. The biggest offenders, and what we're always conscious of, is the unmarried male under the age of 25. If we give them multiple doses tablets, they're just going to sin in the future. So we have got some science that kind of underpins self-management and getting to people to think about the medicines. And David's alluded to this. It affects me. It affects my prescribing habits in the fact that if I've got somebody who's got colitis and I want to give them topical therapy, oral therapy, steroids, calcium and things like that, and I know they're paying for the prescription, we may whittle it down the number of items that we dispense. So managing how you remind, and this is what smartphones are fab because they've got loads of alarms on, but I can remember life before we had smartphones and we had Dosette boxes, little things you could put in your pocket and they alarmed, getting people to stash the medicines all over the place. But it's just kind of making sure that you get people to remind them how to take the medicines. And then look at treatments that when they're well, what do they need to take, and make sure that that's written down and you've got a logged event of knowing what people need to take. And then look at when you're unwell, what behaviours do you have? And I think these are the things that we see quite often. We know that some people try and manage the symptoms themselves within the realms of the medications they've got themselves, but that isn't always the safest option. So if you've got a plan that tells you what to do with your medicines, then you know that what you're doing is safe. And these are some of the scenarios that we see. Concerningly, patients doubling up azathioprine, methotrexate tablets, bringing the Humira jabs forward, those kind of things in an attempt to control the symptoms. You might not tell us, but we know that you do it. So this is a self-management plan. So patients that come through the clinics in Salford who are relatively well get these, and this will be available on the portal eventually, is that we'll chat and we'll get a feel of how you are with your IBD and whether you can manage it and whether I feel happy to support you in self-management. So we'd suggest that if you're having a flare, these are the kind of interventions that we'd put in. We do support the use of prednisolone, but we'd ask you, if you're having more than 2 courses, to get back in contact with the team. Plus, if your symptoms aren't settling after about 2 weeks, then also you need to get in contact with us. But there's other bits that we look at also. we're reinforcing like colorectal cancer surveillance, DEXA scanning, you know, when's that due? So you can go to your GP and campaign with them to get your investigations when you need it. So in conclusion, my 15 minutes.
You're on your own, just about to give you the wave.
Self-management is a process that your IBD team should take you through. It's not about just being given a plan. It's about developing good relationships with your IBD team, where you can articulate what you expect from us, and we're able to say whether we think that's right or wrong. But it's also about giving you the knowledge and the information for you to develop decision-making skills, and giving you the skills that if we ask you to do something, that you feel that you're able to evaluate and consider the pros and cons of that treatment. So I hope that's given you a bit of an insight into self-management, and I'll take questions later.